Hi, I'm Jack Cush, Executive Editor of RheumNow.com. This is July 29th, 2016, and this is the RheumNow Week in Review. I'm coming to you live from San Diego, California, where I'm out here for an advisory meeting this week on RheumNow. Some news from the social media feed. RA risk of infection goes up in patients with interstitial lung disease. It's actually a risk factor for serious infectious events, and the Mayo Clinic group, Eric Madison and colleagues, looked at their cohort and found that patients with interstitial lung disease have a higher risk, that the risk is highest in the first year of diagnosis of interstitial lung disease. Of the many types of interstitial lung disease, NSIP, UIP, and organizing pneumonia actually had the highest risk. This was followed by an increased risk of those who are on greater than 10 milligrams of prednisone per day. Also this week, the FDA put out another warning about fluoroquinolones, such as ciprofloxacin, etc., and their associated side effects being to such a degree that they shouldn't be used as first-line therapy for those who have UTI, URI, bronchitis, etc. The point being that you should use other options when options exist so as to avoid the side effects, including tendinopathies, etc., associated with the fluoroquinolones. An interesting bit of news on a flavonoid called quercetin, an over-the-counter product that has actually been shown to reduce uric acid levels and does so by inhibiting xanthine oxidoreductase. This has not been studied in gout, but in these brief experiments that suggest that maybe this, like vitamin C, may be another way of lowering uric acid in addition to existing approved therapies. In Europe, abatacept made some headlines by getting a recommendation from the CHMP, that's the European equivalent to the Arthritis Advisory Council that advises the FDA. The CHMP advises the EMA about the approval and use of drugs, and they recommended abatacept for first-line use in patients who are methotrexate naive for those with moderate to severe rheumatoid arthritis. The EMA will consider that just as the FDA would, and we'll wait to hear what happens in the future. Lastly, there was a study done in the UK called the Cardera 2 study that actually looked at the use of anakinra in patients with early RA. Strangely enough, even though the anakinra is approved in RA, it did not prove to work out well in patients who had methotrexate with or without anakinra that showed no additional benefit, suggesting that anakinra is really not effective therapy for first-line RA and has no X-ray benefits. A UK audit of 5,000 RA patients showed that 1 in 5 patients had a delay in referral from primary care to rheumatologists. This is sort of against the NICE guidelines in Europe and was sort of somewhat surprising. They did show that the average wait time was different amongst different regions, but in general ranged from 23 to 34 days when patients were referred. Making big news this week at the FDA was the FDA advisory panel recommending the approval of brodalumab, another IL-17 inhibitor for psoriasis. This is notable because brodalumab was initially developed by Amgen and by AstraZeneca, and both companies gave up the drug for fear of the potential labeling restrictions because they found a higher than expected incidence of depression and suicide. Of course, they were asking for those particular symptoms and outcomes, and because of the rates that were seen, it was shelved by those companies and bought up by Valiant Pharmaceuticals, who has taken it to the FDA. Now, whether they will develop the drug, if it were approved, or sell it off, remains to be seen. Other news, other interesting blogs that you should be aware of that I thought were great this week was a blog by my partner Catherine Dow about you should examine the purse first, that there are things to be found in a patient's purse that may be very informative as to why the patient has shoulder, hip, or knee pain. Also a great blog by Doug White and Will Harvey about MACRA, which is the Medicare Access and CHIP reauthorization plan. This goes into effect January 1, 2017, and will strongly influence the way rheumatologists are going to be reimbursed in a value-based assessment change that's going to happen in the future. So be sure to look at that if you want to be updated about the development of MACRA. There's also a report that comes from Gerd Burmester about the long-term safety of adalimumab. Dr. Burmester has written a prior article, which was a sort of seminal article about the safety of adalimumab, and now he updates it with data on 15,000 patients and over 25,000 patient years. Important information about TB, serious infections, hepatitis B events, elevations of total cholesterol, and LDL, which was seen in 13 or so percent. But they also had an important update about pregnancy. They had 74 adalimumab exposed pregnancies and compared that to 80 non-adalimumab exposed pregnancies. And they submitted that data through Otis, and in general they found a surprising number, 40% were exposed to adalimumab in the first trimester, and 44% continued to take adalimumab throughout the pregnancy. Overall, there were no differences in outcomes between those exposed and not exposed, especially with regard to major malformations. And then lastly, a very important paper appeared in Journal of Clinical Investigation about pravastatin and its use in patients with the antiphospholipid syndrome, and that it may benefit fetal outcomes. As you know, the antiphospholipid syndrome and recurrent spontaneous abortions are thought to be related to placental insufficiency and vascular events, although they don't often find actual thrombotic events within the placenta. So trying to investigate this, in the past others have looked at pravastatin as a potentially beneficial therapy in patients who may be at risk for preeclampsia and other complications of pregnancy. In this particular small study of 21 patients, 10 were in a control group that didn't receive pravastatin, 11 received pravastatin, and all patients received low-dose aspirin and low molecular weight heparin. Of those that were in the control group, not on pravastatin, they had a surprising number of bad outcomes. They saw that all were preterm deliveries. 6 out of the 11 actually had survival of the neonate, so half died. And of the surviving neonates, 3 showed abnormal development. On the other hand, the patients who received pravastatin at 20 milligrams a day had full-term births and no complications. So a dramatic outcome may dramatically change the way we treat patients with antiphospholipid syndrome and who may be at risk for complications down the road. That's it for this week in RheumNow. Go to the website to see these citations and others. See you next week.